so privileged to have Dr. Joyce Wald join us after spending a few to 10 hours on the tarmac in New Orleans overnight. She's made it here just in time and is fully caffeinated. She's going to talk to us a little bit about what pharmacologic therapy, what drug to pull first, or what she thinks about when pulling drugs for the management of the cardiogenic shock patient. Joyce?
Thanks, Jason. Thanks, everybody. It has been a whirlwind week. So, started off 4-hour trip from Philly, the whole Philly contingent. Stayed on the airplane for 10 hours. We rerouted to New Orleans. They wouldn't let us off the plane. There was no Wi-Fi for the entire 10 hours. They wouldn't give us alcohol. And then we got here at 3 a.m., 4 a.m. our time, and of course I was petrified I wasn't going to wake up for this lecture, so I'm buzzing on no sleep. So we're gonna run through this, and the other thing that happened to me, these are my disclosures, are my really lovely 7-month-old puppy head-butted me yesterday, so I have this huge bump on my noggin that I covered with makeup, so hopefully you don't see it. So this is a great introduction. Destiny did a great job. And we're going to talk a lot about cardiogenic shock, because this is the shock symposium. And this was a room that I was walking past, and I did a double take, and I was like, oh my gosh, the shock team was not called. And they said, oh, the patient's not in shock. Their CAP is 65. Their index is 2.5. I'm like, holy crap. We have to think about perfusion, not pressure. Perfusion, not pressure. That's going to be my theme, okay? And the talk today is going to be what are the best drips that we should reach for. We all know the SCAI classifications that were alluded to here, and most of what we're going to see in the cardiac ICU are stages C, D, and E. The first questions, and I always want to say we don't lay hands on the patient. I heard you guys talk about POCUS. I heard you guys talk about other things, but we as clinicians have lost the art of physical exam. Lay hands on the patient. They're warm, they're they're cold, they're underperfused. We know we're in trouble, right? How many normal gallbladders have been taken out for hepatic congestion out in the community? So are they cold? What's their MAP? Are they perfusing? Do you have PA catheter capability, and do you have temporary MCS capability? This is our flow sheet at our institution that we use to monitor somebody's invasive hemodynamics, and we look at the interventions to see what happens to the patient. We know there's 3 main categories of shock. We have hypovolemic shock, where we're going to treat with volume, right? But if they're massively bleeding out, maybe you'll put them on a pressor. We have cardiogenic shock, which we're going to focus on, which is going to be decongestion, vasodilatation typically, and then improving perfusion through cardiac output. But remember, it's not about pressure. It's about the cardiac output and the SVR, which is what's going to lead to our perfusion. And then vasodilatory shock, for which we're going to choose a pressor and not necessarily an inotrope, right? Unless they have you have a septic heart failure patient, that's when you might need the inopressor. Let's just talk the basics for a second. We know that we present our hemodynamics in the order in which we float our SWAN, our PA catheter. So the normal RA pressure is 0 to 5. We know there's an A wave, a C wave, and the V wave. The A wave occurs during atrial contraction. The V wave is venous return to the right side of the heart that occurs during ventricular contraction. What happens if you have severe TR? You get a big V wave during ventricular contraction, right? So when we're doing physical exam, we use our A wave as our marker of preload for the for the right side, not the V wave. RV pressure, 15 over 25, over 0 to 5. PA pressure is 15 to 25 over 6 to 12. One key point, if you have a PA catheter in the unit, make sure you know your waveforms, because if that PA catheter flip back into the RV, that can lead to ectopy, so you need to know. There's 3 main differences between your RV tracing and your PA tracing: the pre-diastolic dip on the RV tracing, and that the RV diastolic is the same as your RA when you don't have tricuspid stenosis, right? Dichrotic notch on the pulmonic waveform, and the higher diastolic on the PA pressure. When you wedge the patient, you know that's you take out pulmonary vascular resistance, that's the left-sided preload, and again, if you have severe MR, then you get a big V wave, and your cath lab will say this patient has a wedge of 18 with a V to 40. then you know they have severe MR. You had a patient who had a huge inferior wall MI, and all of a sudden they popped a big V wave, maybe they ruptured a PAP. So you have a lot that you can tell from hemodynamics. So let's take a look at this particular case. You have an RA of 10, a wedge of 25, PA pressures that are elevated, a low cardiac index, and an SVR of 1800. Their blood pressure's fine. One could say the patient's not in shock, but yes, they actually are. Your next question has to be, what is the end organ function? Because if your end organ functions are normal, no lactate, no LFTs, the creatinine's normal, maybe, this is stylistic, you might reach for vasodilators. ARNI, ARB, hydralazine, many in our institution will do nipride. And then we want to target these hemodynamics that you see here. So, why is there music playing? Okay.
I was wondering the same
I know, I'm like, I still have 4.5 minutes. Okay, so, right. So if you go back, so with this patient, this patient has pump reserve. So just by lowering the SVR, their cardiac output went up. This patient didn't need inotropes, okay? Whereas look at the different case, the same exact hemodynamics, but their creatinine is above baseline. For this patient, we are going to choose inotropes to perfuse their end organs, in our institution, milrinone or dobutamine, and then also vasodilate. But look at this patient and the response. The SVR is down to 1,000, but their index is still low. That patient has no pump reserve. That patient's going to be inotrope dependent. This is an example of a case which we don't really have time to go through, so I'm going to skip through it, but it was a patient who had a cardiogenic shock, low EF, and the cardiac index is really low and the SVR is 3,000, but the patient's tachycardic, so they don't want to give inotropic therapy. They instead want to give beta blockers, which is the absolute wrong choice, right? Because cardiac output equals stroke volume times heart rate. You never treat sinus tach. This is a compensatory mechanism. If you have no stroke volume, you drop their heart rate, you're going to put them into worse shock. We see the DILT death test at least a few times a year, and they land on and they always land on ECMO. We'll talk later in the conference about hemodynamic incoherence. So remember that term. That's when you have good markers of macroperfusion, but poor markers of microperfusion, and there's a lot being done on that. These are the different pressures that we could aim for, but when we look at the 10,000-foot view, you can see it here. This is through one of the guidelines that if the patient is underperfused, that you see up here, you assess them. If they're hypotensive, consider early temporary MCS, but if they're normotensive, consider milrinone or dobutamine, okay? If they develop hypotension, then you're gonna probably add norepi. If they start hypotensive, then think about reaching for norepi first. But we know norepi doesn't help that high SVR. It actually makes it worse. So having a PA catheter really is the most important thing, not guessing what you're doing. So I put this one together while I was stuck on the plane in New Orleans. And so they're acutely decompensated. They're normotensive, normal end organs. Then consider diuresis and maximize neurohormonal blockade until you get them out of their low output state. This has to be reached for early as a PA catheter early. Whereas if they're cool and underperfused, normotensive milrinone, hypotensive dobutamine, or norepinephrine. Q1-hour checks to see if they're still in shock. If they're still in shock, as manifest by your physical exam or labs such as lactate or end organ function, you need to be escalating. And I would say if 4 hours pass and they're not responding to your therapies, you have to reach for temporary MCS or escalate that temporary MCS. So with that, I want to thank you, and I am going to have a large cup of coffee.
I think I'm going to borrow the DILT death challenge. Yes.
DILT test. It happens all the time.
Are there any questions from the audience? Nothing. Nothing. I think that was actually perfect. My question is, and I think more for the moderators, panelists, and for yourself, Dr. Wald, how do you circulate this? especially amongst, I see it a lot in our ED providers, where we have like an 18 gauge in the thumb with 30 of norepi running through it.
Exactly.
They finally have somewhat of a blood pressure and they call you because they're like, we think we can't keep them here.
Yeah.
How do we then kind of, again, circulate this knowledge so that drugs or pressors aren't necessarily better?
Right.
You can give your dose of ceftriaxone to meet your sepsis criteria. I'm fine with that. But how do we convince them or have them and educate them to move on to the shock pathway, the cardiogenic shock pathway?
That is great. I think, number one, neo is an overused drug in cardiogenic shock. That's number one. Number two, we do a lot of in-reach. So I'm the medical director of practice development at HUP as well. So we do a lot of outreach for the community, but most importantly, we do a lot of in-reach with EP, our EP providers for those VT storms to get us involved, for the cath lab, as well as for the ER and the hospitalist as well.
Great. Thank you.
We have a question from the audience.
Hi. Yes, I do have one question. Megan Caffey, I'm from Memorial Hermann here at TMC as well.
Great.
As you were mentioning in the beginning of the speech, talking about the disparities from like the community hospitals, looking like a 10-year view, how do we change that culture where you, at least in my experience, I see these patients that come in and they've already gone through all of these things in these community hospitals, and I feel like cardiogenic shock is the last thing that anybody is looking at. So how do we overcome those disparities, and how do we help in that situation?
It's you guys. So it is this group right here that is part of the future, right? And I have an initiative that I'm trying to get one of the large societies to bite on, which is the standardization of education for patients with cardiogenic shock for community hospitals, to be able to use the tools that they have in their toolbox, which are not going to be the same as mine that I have at Penn, right? So using the right drugs when you have it, but knowing when to escalate, exactly as you said. And I think it's education, education, education. I go out 2 to 3 times a month, and many of my community sites, we have monthly meetings to do teachbacks on cases and the outcomes. In one particular institution, we had 3 cases in a row, one that did really poorly, one that did great, and one that actually didn't need advanced therapies but was still a great referral because we were able to rescue them because it was early. So really going back to the community and teaching them what you're doing, and especially to highlight the patient that they sent, I think is really useful.
I'm wondering, it just sort of came to me, if we do the PNAT thing for people to get points for the education and the things that they do in our hospital, but I wonder if the people who are sort of senior staff could make the opportunity to go out to communities and do the teaching as part of that plan, or just as part of their own interest in going out to certainly some of the ones that we see the patients most frequently from, because it doesn't do us any good to sort of say, ooh, it's coming from that hospital again, instead maybe we could be proactive about that and make an effort to create a program that would do that, because we don't currently. So something to think about.
Not a question, but a comment on that specifically. I used to work for Herman for a long, long time. Now I'm an educator for HCA in the Med Center. Something that we started doing was reaching out to our transport teams, who some are here in the room, to understand kind of what the changes they're trying to make, they're trying to achieve. They're not, trying to hurt this person, and making sure that they understand the drug choices do matter. And starting there has then started to leach that out into the communities. And so I think that would be a really great thing for Herman to start, leaching into their transport teams, Lifeline and things like that. So it's given us really good results.
Yeah, I think that's great. Perfusion, Penn Star, Transfer Center actually have a seat at the table on our shock team. So we have not only the various subspecialties, but also fellows, residents, and we have an ER champion, we have a Penn Star champion, we have a perfusion champion. So everyone has a seat at the table, including the advanced care providers. And so,
I think you brought up something really important when you're talking about education and dissemination of education, and that's to have goals. Like everything that we do in medicine, we should have a short and a long-term goal. And I think if you can get people to think about what the goals are when they're pulling a pharmacotherapy or a mechanical support technology or a diagnostic tool, then I think it makes things a lot simpler and more pragmatic. I mean, we're a very goal-oriented group of people. Our parents told us to have goals. Our kids tell us to have goals. My nurses certainly tell me to have goals. So having those goals, I think, are really, really important from an education standpoint.
Great.
Thanks.
Thanks so much. Thank you.